It's a great pleasure and honor to give a presentation in AAO annual session in Philadelphia. Moreover, it is my great privilege to discuss about a challenging subject and very serious subject about molar intrusion for the correction of the open bite and vertical excess using TADs. This is the Google photo where I have practiced for 20 years near Gangnam subway station, which is exactly same name as Gangnam Style. So Gangnam is only, the meaning is south of river, Han River. And also in Gangnam Station, there's another headquarters of Samsung. Personally, I have iPhone. And I have practiced here for 20 years. So I'd like to share with you for 20 years experience, especially about the TADs. My title is Molar Intrusion Using TADs. The key element to correcting anterior open bite and or vertical excess problems. Why I differentiate two anterior open bite and vertical excess. I'm going to tell you later. I'd like to start with the question, what is anterior open bite? I would like to simulate anterior open bite. Anterior open bite is as the mandible closes along the hinge axis, if the molars occlude first and there is no contact in the anteriors, that is anterior open bite. If the molars, that's why I think that molar intrusion is the treatment of choice because it is addressing the origin of this problem. Whereas the conventional treatment, such as extruding the incisors, is merely the hitting the bush around technique. Then how much anterior open bite closes when the molars are intruded by 1 millimeter? According to the Dr. Kuhn's classic paper, 3 millimeter of anterior bite will be closed by mandibular counterclockwise rotation, resulting from 1 millimeter molar intrusion. However, other previous studies have reported the range between 2 millimeter to 3 millimeter. As we all know, orthodontists have experienced difficulty not only in treating the open bite itself, but also in retaining the treatment result. Today, I would like to focus on the skeletal open bite. Dr. Bean introduced 7 possible non-surgical methods to correct the skeletal open bite. However, in terms of efficiency and stability, I don't think I could guarantee treatment to the patient with the latter 5 methods. In other words, I cannot demand a decent amount of orthodontic fee because I'm not confident with the treatment. So I'd like to talk about the rest of 2 treatment choices. As for me, I used to use multi-loop mechanics, as Professor Kim already presented to correct the open bite prior to the development of TADs. Because multi-loop mechanic is very efficient technique to correct the open bite. However, according to the paper written by Dr. Kim, with multi-loop techniques, the anteriors, especially lower anteriors, extrude and the mandibular plane opens up because of vigorous usage of elastics. The first treatment method Dr. Bean recommended is mini implant. He did not mention about the mini screws because this paper was introduced more than 10 years ago. Today, I'm happy to show you the mini screw implant could function as good as the mini plate. Dr. Sugawara intruded mandibular molars with mini plates, and Dr. Sherwood introduced maxillary intrusion by maxillary mini plate. This is the Dr. Sherwood's paper, and as we all know, he used the zygomatic mini plate. This is the photos in the paper of Dr. Sherwood. If we could get the same result as this with miniscule implants, the patients could avoid this kind of surgical procedure. This is the photos in the Dr. Sherwood's paper treated using zygomatic mini plates. So I changed it, this setting, and this is the similar photos of my patient, which I'm going to show you today, treated with one mid-palatal mini screw and extracting third molars only. So I'm going to show you this case later. Recently, my clinical skill has improved a little to correct the open bite without extracting bicuspid. This is non-extraction case, which is more difficult than the extraction cases. I will show you this case soon. Okay, I'd like to introduce table of contents today. Quite complicated table of contents. I thought the screen was bigger. It's bigger, so sorry for the audience in the back. If I briefly introduce the list of contents, at first, I'm going to talk about why I classify the vertical excess into the two categories, which are the vertical excess with anterior open bite and the vertical excess with normal anterior overbite. Secondly, and thirdly, I will talk about which side should you intrude, upper or lower, and how. Fourthly, I'm going to introduce the skeletal change. Number 5, I'm going to introduce synergic effect of TAD, muscle training, and extractions. And number 6, last but not the least, I will show you the 10-year retention records of the TAD-driven molar intrusion case. Number 1, 2 types of vertical excess. Why did I classify the vertical excess to 2 types? It is because the